What we learned about children with Down syndrome since it was first described in like about 150 years ago was a lot, but there are still a lot to learn. And that is why having a registry is very important to learn about specific population. Most of the studies were done in Europe or the United States, and there are specific characteristics and comorbidities that are specific to our area. So the goal of the Gulf Region Registry is to serve to identify unique characteristics for our population. At the same time, it will provide a source of information for families, for researchers, for healthcare providers in order to promote clinical care that is provided for children with Down syndrome and for research and for advocacy. I want just to give a little bit background on Down syndrome program at Tawam Hospital. It was established back in 2012 and currently is taking care of 175 children with Down syndrome at different ages. Few of them are even adults. It has three missions. The first mission is to do the first mission is clinical and basically to implement evidence-based medical care for patients with Down syndrome as per American Academy of Pediatrics guidelines that we are using currently. The second mission is for advocacy, as we need to increase awareness among all levels, including physicians, community teachers, and families about children and strengths of these children with Down syndrome. And the third mission is about research, which includes also the Gulf Region Registry for Down syndrome. Actually, the children with Down syndrome have recognized phenotypes, and many times they are prejudged based on that. And most of the time, the expectations are set very low for them. And the reason of that is because there is lack of awareness, especially in areas like in our area, among all levels. So that's why we need to use the registry to increase awareness among physicians and community, and to help children to reach their potential by providing the medical care and the support they need. I want to describe the Gulf Region Registry for Down syndrome. The reason we called it Gulf Down Syndrome Registry is because it does not include United Arab Emirates. It also includes some other children who join our program from the neighborhood countries. Also, because we are multicultural community, some kids belong to other countries in North Africa or even from the Middle East who come and attend our program. And the third thing, because we don't have any other registry in the region, so it will be an opportunity to have a unified registry for all the area, since we share a lot of cultural and genetic background. So this actually summarizes the demographic characteristics that we are looking at when we collect our data, including some characteristics that are related to the participants themselves, including the age and the gender and the nationality, and some are related to the family, including like the maternal age, the size of the family, the level of education of the family, and so on. The second part will include the comorbidity variables, and that include a list of diagnoses that was first agreed on by the co-investigators regarding the definition of each diagnosis, and inter-rater reliability testing was done for all co-investigators before the data collection started in order to be all unified on the same definition of diagnosis. After these comorbidity variables were collected, they were entered in SPSS software, which is capable of organizing hundreds of diagnoses in system-based manner. And adding to that, Dr. Corder, who was the one who designed this study, she added a lifespan registry to include diagnoses unique for adults with Down syndrome, hoping in the future that our colleagues in family medicine will provide care for individuals with Down syndrome and register them in the Gulf Down syndrome registry, and also provide care for them in our clinic. These comorbidities include dementia, depression, polycystic ovarian disease, testicular cancer, and so on. Now, this is the first slide that indicate the number of the children in our study who were entered in our study. The total was 146, and this slide shows that 93 of them, which accounts for 64%, were males. And this male predominance was also reported by many investigators throughout the world. So it is not unique to our area, and the reason behind that is unclear. The second characteristic that we looked at was the nationality, and we were able to identify 137 out of the 146 patients' nationality from the retrospective child review. And we found out that most of them are Emirati from UAE, and a good portion, a total of 40, were Arab, non-Emirati, and they belong to the surrounding areas such as Oman, Kuwait, and Saudi Arabia. A few from North Africa, including Algeria, Morocco, and Egypt, and few from the Middle East, including Jordan, Syria, and Palestine. The maternal age was identified through the retrospective study in only 55 of our children. And if you notice that most of the children with Down syndrome are born for older maternal age, over 35 years, and only 36% were born for younger mothers, which is different than what we know from other statistics all over the world. About 80% are born to younger mothers. I cannot comment much on this because the total number that was collected only for 55 of our children. And the other thing, it could reflect some of the reality, because this might reflect the maternal age range in our population, as the age range was between 17 and 48, and in many other communities and populations, we don't see many deliveries occurring after 40 years of age. As you can see, the median maternal age is 37. It would be more interesting to find out what will be the final result after we do the prospective part of this study. And actually, we looked at the maternal diabetes, and we found no cases of maternal diabetes. We found only type 2 of maternal type 1 diabetes. I mean, we found gestational diabetes and type 2 diabetes in about 23% of our mothers. And actually, the gestational diabetes is almost equivalent to what we see in our general population. We have a high rate of gestational diabetes among our mothers who even don't have babies with Down syndrome. The next characteristic that we looked at was the number of the siblings in the family. And again, this is very interesting because data between 50s and 70s, before the abortion become more common, it indicates that most of the children with Down syndrome are the firstborn for older maternal age. In our case, as you can see, most of our children are born to families with many siblings. More than 50% of them have 4 to 14 siblings in the household. And again, it is very difficult to look at this by itself, at this slide by itself, unless we analyze it according to the maternal age. There is some advantage of having large-size family for a child born with Down syndrome, as they have more chance to interact with other kids and learn from them. While on the other hand, the advanced maternal age might be a negative factor, as the mother might be less educated and has less accessibility to early intervention and transportation and medical care. Also, we looked at family history of Down syndrome, and 16% reported another family member with Down syndrome, but usually it's distinct family. Only one sibling had a brother or sister with Down syndrome. The others were distant relatives, so it very likely were not related genetically to these kids. Again, consanguinity, although it was documented in 39 out of the 146 families that we reviewed the chart for the children with Down syndrome, but as you can see, it is very common, and almost 50% of the time you find some sort of consanguinity in the family, from first degree to second degree cousin to unspecified consanguinity. The karyotyping also was reviewed for these children, and basically it reflects what we see in other studies in other places in the world. Most of the children who are born with Down syndrome are due to non-familial trisomy 21, and about 3 to 4% are due to unbalanced translocation between chromosome 21 and 14 that many times could be de novo, and 2% are the ones who have the two types of cells, the 46 chromosome and the 46 plus that extra 21 chromosome, which we call the mosaic type. The prenatal investigations that was done for most of these mothers included mainly an ultrasound, and this was found in only 54 of our out of the 146 mothers, and the method for screening was mainly ultrasound. The maternal serum testing is not used universally in Saha hospitals where this study was conducted, and I don't believe many places also use the serum testing in UAE. So the main screening test was the ultrasound, and the diagnostic test was the amniocentesis or CVS, which was done in 9.3% of these mothers and was diagnostic for Down syndrome. And this can be reflected on this slide about the age at confirmed diagnosis. As we can see, only very few cases were diagnosed prenatally, most of them within the first 2 weeks of life, and some were somehow delayed. It could be also related to gestational age, that the features were not very clear at time of birth, as some of these kids were born prematurely. Now, the advantage of having prenatal diagnosis is basically to provide support and to provide counseling for the family before the baby is born, and in case the baby has any kind of cardiac defect or require some kind of special treatment, the family will be ready before the baby is born. So this is the advantage of the prenatal diagnosis in our community. Now I'm going to move to the second part of the study, which is looking at the comorbidities that we found in our population, and I will start with the cardiovascular system. Actually, 100 out of 146 children were found to have some kind of cardiovascular disease, not necessarily malformation, because diagnoses such as pulmonary hypertension or valvular involvement were included in the study. However, the cardiovascular malformation are summarized in this slide and showing the PDA being the most common malformation that we found in our children with Down syndrome, followed with ASD ASD, VSD, PFO, and AV canal. One little thing I want to point out, compared to statistics from other places, it shows that they kind of classified these malformations as primary and secondary, and we don't have this type of classification. So I could not compare it with other areas. Like in some other statistics, PDA as a primary diagnosis was only found in 4%. And there is a good number that have more than one diagnosis that they could have, let's say, PFO and VSD together, or AV canal and PDA. So this needs further analysis to know more specifics about the cardiovascular malformation in our children. The next one is the gastrointestinal surgeries, and as Dr. Fatima mentioned before, that children with Down syndrome have gastrointestinal comorbidities, including conditions that require surgery, and the most characteristic one is the duodenal atresia or stenosis, and in our population we found 4 children who had that condition required surgery, and the other 2 conditions were the anal atresia and the Hirschsprung disease, which is a little bit higher than the general population. Hirschsprung disease was reported in less than 1% of children with Down syndrome, but in our scenario we had about 2 cases, around 2% of our participants. Other gastrointestinal abnormalities or comorbidities are medical, and the most common from what I found from the data collection was constipation. It was reported in about 46% of our children, followed by feeding difficulty and failure to thrive. Celiac disease, none of the cases was reported in our population. And the next one, which is very important, is the ENT condition that was reported in our case in about 83 of the total number of our children, which is about 56%. I want just to point out that some of the diagnoses are somehow related, like snoring and obstructive sleep apnea could be related to tonsillar and adenoid hypertrophy. The only thing I want to point out is about hearing loss. The sensorineural hearing loss was reported in 4 cases, which is about 2 to 3%, and that's much less than what's reported in other statistics. It's about 15%, and same thing for the conductive hearing loss. It was reported only in 30% of our cases, and in other resources was 50 to 70%. This also could be related to the age group that we are dealing with, because as the children gets older, they might develop more and more conditions of hearing loss and conductive hearing loss and sensory hearing loss. And maybe when we have more numbers, or when this study is more advanced, the numbers might change a little bit. The same thing applies when we looked at ophthalmology conditions, and it was reported in about 59% of our children, and the most common were the ones that related to refractory errors, including hyperopia and myopia and strabismus. Cataract was found in 4 of our children, which is about 3%. Again, the ophthalmology conditions increase in prevalence as the child gets older. So it was also reported in about 80% in other studies and other populations. But again, I believe because our population, probably the age range is younger, and we need to follow them longer to maybe to find out more of these ophthalmology conditions. The next one is very interesting about the genitourinary conditions, and hypospadias was reported in higher rate in children with Down syndrome, but in most reports it was 1 in 250. In our population it was much higher, and about 8%, 8 to 9% actually of our male children had hypospadias. We are not sure why we have this high rate of hypospadias. It could be also related to consanguinity that we have in our population. On the other hand, according to American Academy of Pediatrics guidelines, they did not give recommendation regarding screening for urinary malformation, because they needed more data to make these recommendations. And I believe after we have these data of having hydronephrosis in about 4% of our children, which is caused probably by VUJ and UPJ obstruction. It might be a field to study in children as doing like screening tests with KUB ultrasound and find out the prevalence, and based on that come up with recommendations. As it was also asked by the American Academy of Pediatrics to do studies like that. For endocrine conditions, children with Down syndrome at a higher risk for different endocrine conditions. The three main ones are the hypothyroidism, and in our population, it was reported in about 15% of our kids. 6 of them were congenital, and 14 were secondary or acquired. And diabetes type 1 was reported only in 3 cases, and in other studies it's showing that it's 3 times more. Still, we need more time to see if we will have higher prevalence of diabetes among our children with Down syndrome. On the other hand, obesity was reported only in 21%, and again, this could be for younger, because we have younger age group, and usually the obesity becomes more prevalent as the child gets older. I try to look at the age group. It is between 1 and 16 years of age, but most of the kids who are coming to our clinic are between 3 to 6 years of age, so that's why they are still at the younger age group. And so the total, we found over 1,000 of comorbidities in all these children, and each child has an average of 8 conditions. The good news is most of these conditions are treatable. So that is why implementing American Academy of Pediatric guidelines and evidence-based medicine to provide continuous care for these children will be helpful in giving them the best outcome. And this is a rough comparison of the prevalence among the 3 statistics that we have. The first column actually represents the Gulf Down Syndrome Registry, and the second is what is posted on the American Academy Guidelines references, and this is the NIH Down Syndrome Connect, and this one actually is a very good resource for families, researchers, and clinicians, as it is the NIH registry program for Down syndrome. It is self-registry. The family can do that, and from all over the world, and they provide a lot of data about the Down syndrome globally. So if we look at these, they are kind of comparable with each other, and I believe we need more time to decide how we can compare ourselves to other statistics in the world. And what we found out, the main differences that we found out in our studies was the advanced maternal age, as I mentioned earlier, and we need to look at the prospective study to decide on that, and the high prevalence of genitourinary abnormality, the large family size that we have, few prenatal diagnoses, and high rate of consanguinity. The limitations, because this is a retrospective study, so it has this limitation, and also fragmented medical care, because these kids get care in different Saha clinics and hospitals, so clinicians can have different perception on diagnosis. So these are the limitations, and probably the third one is what I mentioned, is the age group, that we tend to have more younger kids than other studies. I want just to acknowledge the DS Connect, which is the Down Syndrome Registry by NIH, and is supported by Eunice Kennedy Shriver, and they provided a lot of support for Dr. Corder while she was collecting data, and they gave her advice on this study. And I want just to mention the names of the people who worked on this study. Dr. Jennifer Corder is the pediatric consultant who established the Down syndrome program at Tawam Hospital. And these are our residents in pediatric department, which is ACGME accredited by US. And the last physician is actually a family physician that is very helpful to have in our program to take care of our adults. These are the references. And last, this is Dr. Jennifer, who was the one who did this study at Tawam Hospital, if anybody needs to communicate with her for further clarification and question. And thank you very much.